All right, we'll wait for people to roll in. We'll get started shortly after 12. Okay, now it feels shortly after 12. Hi, everyone, and thanks for joining our discussion today, Forecasting Healthcare, AI's role in the years ahead. My name is Megan Chamberlain. I'm a content marketing manager here at IMO, and I will serve as your host for today's panel. Before we get started, I have a couple of housekeeping items. Firstly, this session will be recorded. You can watch it later if you're watching it in the future because you couldn't make it today. Love that for you. It'll all be available after the webinar as well. All attendees will be in listen-only mode, but at the end of the webinar, we will have a Q&A session. So as we're discussing, I urge you to take advantage of the Q&A function on your Zoom console. And now I'm very excited to introduce today's speakers. First, we have Dr. Inez Maria Vigil, the Senior Vice President of Services and Transformation at Clarify Health. We have Dr. Xiaoyan Wang, Senior Vice President of Life Science Solutions at IMO, and Dr. Amal Bala, Senior Director of Clinical Informatics at IMO. Now, we don't need a crystal ball or some meteorologist of tech trends to tell us that AI is here to stay. And considering the continuing advancements in generative AI, including LLMs like ChatGPT, many are wondering about ways to improve the healthcare industry. What are some of the ways that it may realistically grow and improve with this technology, and what are some of the concerns? We prepared a few questions for our panelists to explore this further, so we're going to go ahead and jump in. With major advances in AI and machine learning, companies across the healthcare industry are exploring ways to adopt this technology. Can each of you share how your organization is currently leveraging or planning to leverage AI and machine learning? Xiaoyan, I know that you have a specialty in life sciences, so let's start with you.
Thank you so much, Megan. Yes, this is a great question to open up the discussion. So I think I can start with the science itself. So large language models, generative AI has been such a buzzword in the past year, tremendously being so publicly to everybody nowadays. So specific-wise, this is not like a new technology. So GPT-1 was up about 6 years ago. Across the years, there was GPT-1, 2, 3, and ChatGPT was based on 3.5. Now it's GPT-4. So historically, that's the GPT or GPT-based technology now is because they run and trained in huge amount of data and with the technology called reinforcement learning. So every time you use a system, you actually optimize the system. So that's why it's getting better and better. It's becoming so like, and its intelligence. So it is extremely powerful as many use cases have been demonstrated in the past year. So every day you see some new models built, new application built. There was a lot of excitement in the healthcare and life science areas. So I'm all here. We actually have about 3 new initiatives around this area. The first one is we set up a large language model service which support users. You can train your own data and then generate your own user cases, your own applications using the services. So that's the first thing we support. The second one is we're actually training a biomedical specific NLP, which is trained using our terminology. As you probably know, IML terminology is interfacing terminology. The beautiful part of it is actually very rich and granular. To give you an example, for disease, let's see if it's lipodystrophy. It is a disease which has 2 forms. One is a genetic causing disease. The other is acquired version of it. So under the genetic cause of it, there are 9 biomarkers causing those diseases. IMO code actually code all those genetic mutation cause the disease differently. So within those very rich content knowledge and trained on massive data, our model is actually very strong and powerful, specifically in the clinical medicine domain. So that is the second service we do. The third one is in life sciences space. So I run the team here in the lab. We call ourselves life science innovations and solutions. So we have been built a lot of platforms and solutions from the drug discovery to the implementation to the clinical development and also FDA approval to the post-marketing surveillance. To give you a few examples, we built a platform, automated literature review and analysis. What we do is we collect all the literatures in the fields and generate a knowledge graph and then learn new knowledge from it. So discover new knowledge based on previous disconnected knowledge. So another thing is the thing we call social media listening. What we do is we generate, patient-reported journeys from, Twitter, now called X, I guess, the YouTube, Reddit. Then you can really listen how, patients really talk about their experiences in those care journeys. So another is we also have a lot of solutions on AI-supported clinical trial optimization. So all of those we've been supporting and having for tooling around. So I can stop here for life science part. Yep.
Thank you. I enjoyed the life science part quite a lot. Amal, I know you've talked about provider enablement in this space. Do you want to touch on that?
Oh, definitely. So provider enablement. So just to give you a little bit of background, so Cheyenne and I, we work very closely together. And thank you for highlighting the efforts of the clinical team. They've been doing that, creating that content for years now. And, that's what we pride ourselves at IMO is that rich clinical experience or that content behind the scenes that enable our products. And so when we look at generative AI, it's always about the semantics. That's what happens to it. And so with this rich corpus of text or this rich lexicon that IMO has, developed over the last 25 years, that really allows us to play in this space pretty synergistically, enabling that language model to effectively start talking about code, codification, and terminology. But for the provider workflow is how do you integrate that? And so longitudinally, what you think about is like, hey, well, an ICD-10 code is not how a clinician thinks. A clinician thinks about all the features that they're looking at the patient. When I say features, it could be lab testing, this interaction with them, the overall environment, and how do they come up with that diagnosis? So how we look at enabling our clinicians is through technology, of course, enabling this technology, providing rich tooling such as enhanced problem list management, or maybe even going down to a co-pilot situation and helping discover these really edge case type of rare diseases that may be there, but not really presenting themselves as the patient. So that's how we're also looking at investing it within IMO too, with generative AI. But my organization, I'm also an operational director too. So here's a scary fact. AMIA, I'm a member of AMIA, proud member of it, been a member for years. AMIA just disclosed that they have 5,500 informaticians registered with them. To give you a kind of like what that means in the big gambit of informatics and healthcare, there's 12,000 roughly practicing oncologists in this country. So if you think how specific oncology is in the gambit of healthcare, informaticians are even a rare breed within that in the healthcare space. So as an operational director, I have to look at, there's not a big pool of individuals. There's always a firefight to try to get this type of top talent. So how do I operationalize our teams more effectively? Where can we use generative AI to enhance our maybe terminology in that space, creating new terms, codifying them, semantically aligning them, or even if I have to bring something net new, because medicine is constantly evolving. There's always a new publication. I know, Cheyenne, if I ask you every day what new came out, I know you would send me a publication every day of what something new came out that's disrupting our space, even from the insights that are derived from this type of technology. So I take it from two perspectives, is provider enablement and then operational efficiencies. So I'll pause there.
Thanks, Amal. Inez, I know that Clarify Health has a different perspective as well and talking about the practical uses mostly. Do you want to go into that? You may be on mute. You may.
Well, I'll tell you, and not specific to Clarify Health, as a physician who's been working in analytics at the cross-section and intersections of analytics and the business of health, and really looking at practical ways that organizations across the US can deploy a lot of this technology now and for the betterment, and not necessarily have to really tease through or understand the interworkings of it, which is I think one of the hardest parts, is like, what do you believe? How much do you believe? And how transparent is it? It's really thinking about how much data exists in healthcare today that didn't exist even previously. More than 30% of the world's data volume is being generated by the healthcare industry, and that's outpacing manufacturing, financial services, and media and entertainment. So if you think about how much data are in those industries, and then you think about how much is in healthcare now, there is no way a clinician can keep up with like Cheyenne mentioned, the clinical evidence base, how to tailor that to the patients that they serve, that they're seeing in a clinical basis day after day in the 15 or 20, or even if you fought for it, 30 minutes that you get to see a patient and spend time with them, let alone choose the right, most tailored, advanced, predictive information to apply to them in that clinical setting to the betterment of their health outcomes. And so I think if we take the major advances in AI and machine learning really come from its ability to really process data quickly, to scan through it, just like Cheyenne said, scan through it, pick out those insights that are most meaningful and most applicable, apply them at the right time for the right patient in the right clinical setting, and make a difference, make an impact. And I think what this technology can do is speed that up for us.
Absolutely. And you actually provided the perfect transition into the next question that I would love for you to start if you don't mind. What recommendations do you have for companies in the industry to stay ahead and effectively leverage these innovations, all this tech? And are there specific steps or strategies that you would recommend for staying at the forefront as everything is changing? I know we've talked about Cheyenne has a new study every day that's constantly evolving. So like, how do you stay on the pulse?
Yeah, it's interesting because I work with a breadth and depth of healthcare payer organizations and provider organizations across the US. And right now, just in its general response to AI, you see some organizations embracing it and wanting to learn and understand and go deep to see what it's all about and how to get familiar with it and how to use it in very practical ways for even your own personal use. And then you see organizations who are so almost afraid of it that they've mandated across their organizations that it not be used unless it's an approved use case, approved by some unknown person in some unknown department of unknown role kind of clarity, as well as like their experience in working with this technology. The challenge is that, everybody wants to do it. Nobody knows how or what the right way is. And then how do we use it ethically and responsibly, right? Those are all really tough questions that everybody's battling as they work through it. And my best advice and my, best practice in approaching it, because I'm one of the embracers, the adopters of early technology, and I'm willing to work through the kinks and the issues, and I'm willing to take things at the value of optimistic scrutiny, And really the advice that I would have is really understand, ask as many questions, be curious about it, but really ground yourself in what the practical use is, with a practical use case that can be applied for patients where it makes the most immediate sense for it to work. And one of the examples that Clarify is not doing, but I've looked at other companies that are, is using AI to capture the moment in a hospital setting where a patient needs one-on-one care. They need one-on-one care because they really need the supervision, not because they need a nurse doing anything or a clinician doing everything 24/7. They just need to be supervised. And so how can we use technology and AI and machine learning to really capture that patient's environment, process the data at a speed that even humans might not be able to achieve, and sense when, either through the technology in the bed, technology on a camera or a handheld device, sense when that patient is moving, sense if they're unstable in their ability to walk, or sense whether or not they're going to fall. that is a very practical use case where AI and ML can be used to enhance the clinical kind of outcomes of patients in a very positive way, and where a human doesn't necessarily need to be involved, and that human can be moved to work at the top of their license on other things, and therefore expanding access, reducing cost, and really making it so that we're all sharing kind of the learnings and the practicality of using these types of technologies. And I'm interested to hear what Cheyenne and Amal have to say about this too.
Yeah, and you lined up so beautifully, how those things we should consider in the patient workflow type of applications. Really nice, and I agree everything you said. I can switch gear a little bit to talk about life science journey. It's very interesting, AI is such big words. In the past, we touched almost everybody. However, there's a lot of disbelief and also AI hype kind of thing to think when it's going to be over this time. So, there's this and that all over the place at the same time. So I myself actually engaged a lot of conference panels, presentations in the past year. And, AI, in the life science space, on one hand, I heard those companies put up their beautiful slides, demo to show, we solved all, at least many of the challenges already. Here it is, just you take it and use it. And then on the other hand, you hear those, pharma teams to say, okay, this is a small thing, it remains not solved, and then everything is still in the original place, nothing really moved. So there are those voices I heard at the same session sometimes. So I think the recommendations I have at this point is number one, trust the science. So really run your user cases and scientifically prove it first to make sure it's realistically can be deployed. And then the second one is a solid implementation and as you just laid out in the life science space, also really understand your users, understand systematically upstream and downstreams and what are really affect all those. So that's really my recommendation, trust the science and solid implementation and really fully understand your users. I can pause here.
I think I'll jump in. Completely agree with both Cheyenne and Inez. This is amazing technology. We're actually really it's coming on. I'll get on my philosophical soapbox right now a little bit, but we're at a new type of industrial revolution, and that's what's going on. Is this technology is basically we're at the precipice of seeing something unfold that we, even though the previous generation was not able to see. So this is how I like to think about it: is this technology. So there's a lot going on behind the scenes, and the way that we kind of keep ourselves is really utilize this technology in a very scientific manner. It takes a lot of experimentation to come up to make sure that what you've done, what you built out longitudinally, is fulfilling the exact use cases. Just because of how pervasive this technology can be, and how encompassing it can also be with the content that goes into training it too. Was it Cheyenne? GPT-4 had 1.8 trillion inputs or something into it in comparison to its predecessor. And so you can think about that as like, wow. But how do you kind of make this technology work for yourself? And that's going to always take on the experimentation route, making sure that you have a very judicious use case that you've really vetted out, a good hypothesis, use the scientific method to really approach it. And then say at the end is you also have to make the determination is this the right technology or not? Because you also have that type of balancing act. Sometimes the older technology, even though it is older, it gets the job done cheaper and more efficiently versus what is being done with generative AI. So you have to do that balancing act too. Additionally, what we also like to keep in play in our mind in our field in healthcare too is the regulatory implications that go on. How does that impact us? President Biden just sent out an EO about some guidance about how AI should be working in this domain. ONC had a huge announcement going out. The WHO just came out with some more language too. So you have to also keep in mind that even though we may come up with some amazing solution, there's also regulatory bodies that we have to abide by. There's also, I mean, do we classify this as a medical device? Then you have to go through the FDA cycles to make sure that it goes through that. So like you have to think about it strategically from multiple lenses and invest in that type of directionality and scoping of your use cases and your activities behind it. So I'll leave with that.
That was perfect. There's so much to consider. All right, so let's stick with LLMs and generative AI capabilities. And we probably already touched on it a bit, but how might these technologies contribute to solving the connectivity issues across diverse healthcare data? And what benefits could this bring to the healthcare industry as a whole? Cheyenne, I know we've talked about Odyssey a little bit. Can you start us there?
Totally, yes. So data activity and also interoperability have been a huge issue in healthcare. Every day we have trillions of data processed, created across millions of organizations. So guess what? You know, that they don't talk to each other. So one patient was treated at one hospital, then moved to another one and lost all the source data, unless, you know, they have those oral communications on, but lots of source data really knocked out to each other. So in the past 20 years, you know, a lot of public and private sectors, there was lots of proposals, initiatives really proposed to solve this problem. Health Information Exchange, HIE, from the government have been really targeted to solve this, but guess what? Nothing is really successful in the last 20 years. The challenge has been because every hospital have their own way calling something a different way. So data in different format, in different data models, and in different language, and every specialty have their jargons to use, and it's nothing in common. So common data model was an idea come from scientific community in the past almost 20 years also. You know, we're starting from I2B2, PicoNet, ChinaX, and then now to the OMAP, which was studied from Columbia while I was trained on my PhD back to 15 years ago. So OMAP has been very successful common data model in the past 10, 15 years, and leading by George Ripsack. So he himself really is a researcher, physician, and also informatician. So he spent a lot of time, he actually just stepped off the chair of the DBMF of Columbia, just dedicated his time on this. So the community really putting together lots of efforts on how we really call the same thing the same way. We define the same data as the same data format, the same data model. If I run a query, say how many patients I have, the pediatrician I have here. So we call type 2, type 1 the same way, and then the same query can be running in the different clinical sets also across the whole network. You can just run the same query without knowing what it is. So that makes really realistically, we can analyze millions of data. Last time I checked, it's 800 million data are not connected through the model. Thinking about that, so you can analyze, you don't really have all this data, but don't worry, you can still run your analysis across those clinical organizations, across those millions of data to do your work, which is extremely important for, our knowledge of disease understanding, especially, for rare disease, thinking about lots of unknowns on those diseases because it's rare. Every hospital, maybe historically for the last 20 years, they only treat 20 patients in let's say Prader-Willi syndrome. Then another one have 15. Then nobody really understand much about those disease and those patients. We cannot treat them well because of the knowledge really not there. Now with the network, you can analyze hundreds, thousands of those. You can really map up the whole patient journey, the natural history of the disease, and then leading the drug discovery. That is a huge success for the last 10, 15 years on that area. Now with the technology of AI, large language models, we can not only make those currently structured data becoming readily available, especially clinical unstructured data, clinical notes, for example, which are, locked in 80% of clinical information only existed in notes formats. And then now this technology can make those things really hidden, and really you can analyze the data hidden in the clinical notes, for example. I think I can stop here for now. Yeah.
We will come back to unstructured data in the next question, but I quickly want to bump to Amal to talk about this from an interoperability and semantic
Yeah.
alignment perspective.
I knew that question was going to come up. So, what Cheyenne was mentioning is a lot of effort going into secondary use of EHR data or clinical data. And so when we think about it from an interoperability and a semantic alignment of known concepts to a schema, let's say FHIR or HL7V2X, whatever you want to go with, some flavor like that, there's a lot of terminology that goes into it. And the field is very opinionated. So the inputs to get to that part is quite opinionated. So you put myself in front of a patient, and you put the same patient in front of Inez. We may come up with the same diagnosis, but our approaches, our training is fundamentally different. And so what I look at this type of technology is to allow the clinician to behave like a clinician, document effectively. Hey, there's even technology going out there with augmented speech and speech to text. Fine, that's understanding the entire room of what's going on. Maybe let's add some. I love the idea of body movement monitoring too, to see their body languages and how they are, and that could be the inputs into the entire equation. But where this technology comes in is to help really disambiguate it, and then semantically align that to a known code system that is then utilized in some other downstream activity, like a large network federated analysis in Odyssey, or something as easy as clinical triggers for CDS support. So everything else behind the scenes may be built bespoke on terminology or code systems, but that large language model in front of it can help us disambiguate that clinical interaction to something that is known. And that's where IMO, we feel like we play really well in that area too. So with our clinical terminology.
I do feel like listening to all of your responses, I keep going back to what Inez said about optimistic scrutiny, and there's just such an optimism coming from everybody, and I love it, because I think that's better than people being afraid of it. All right, let's go back to unstructured data. With such a large portion of clinical data being, I think we said 80% in unstructured formats, how can generative AI address the challenges of unstructured data in healthcare, and what improvements do you foresee in healthcare data management and process efficiency? And we'll start with Xiaoyan or Inez. Duke it out.
Okay, I can start on that. So let me just give a general, very brief introduction on, what do we call by structured, unstructured. So, in our whole world, the data are two formats. One is structured, which is something like medications, the providers provide to their patients, which in tablet format, or lab test from a testing company sends you as a tablet format. Those are structured, relatively easy to be analyzed. So they still need quite some work on normalization, terminology, Amal you just speak to, but it's relatively readily to be analyzed. The other kind is unstructured, which including, of course, clinical notes, imaging, and also some of the voice recordings, for example. All those are not readily to be analyzed. They need to be processed to get the really downstream analysis on that. So unstructured data, I know, GPT started as large language model, so language is the first thing they really do. I think we talk about a little bit on clinical notes and the story. Surprising, it works extremely well on imaging analysis also, and also the voice to text also touch a little bit. So nowadays, I think on those ends, there was two sides of it. The first is on the documentation end, all the data documentations, thinking about it, you can just say what you want to document, and then it just automatically transforms that into text. The other is you just write a couple of keywords, and then the system automatically generated. You just need to do manual editing on those. So those are, the advancements we can foresee in the future. Actually, there are companies already claim they have the solution already deployed, and tested and all that. But those are things are, probably in the near future on the documentation end. The other is on the data processing end, which I touched a little bit earlier on, how NLP, now large language models, really can process all the data to make them extract all those data into computable format, and then you do an analysis around it. So another way to think about it is, let's say, now you have all the data, you can actually do we call it a real-time NLP, which are very hard to do. I was consulting a company before many years ago. They actually was thinking to do a real-time NLP, which is very hard because a lot of computation burden behind it, and also implementation takes a very long time. But now large language model make it a lot easier and faster. And thinking about it, so now when you go to doctor's office, so for the doctor to understand your history, and then you spend 15 minutes really give the picture of, where you come from, what do you do, or how your disease is really coming. But now the provider open up the application EHR, they already see the patient journey type of data to really see across the timeline, your lab test, your disease, and your medication has been given. So data summarization, visualization become a lot easier nowadays with the technology. I mean, I can go on and on, talk about a lot of possible scenarios, but those are two kind of, documentation and processing realization, and I can think of for now. Yeah.
Well, I'd love to play off of that, like directly. So thinking about documentation, believe it or not, I'm old enough to have written notes and run around to different charts to read my other clinicians' notes on our mutual patients. I'm also remember a time when we then entered them into electronic medical records that were never built to collect and report on the data that we do today. And then the advancement was, I'm going to like speak into, a recorded version that would be transcribed, right? And that transcription would be done by humans. That's now done by technology, right? So if we think about the advancements that we've had already to date in my practicing career, like I embrace the day that Cheyenne's talking about, which is like the ability to actually even just think it, and it gets laid out into structured data in a way that can be picked up and used immediately and merged together, what Amal was saying, interoperably into multiple different data sets together. The speed at which then on the processing side, you can develop an insight and that gets repeated back to me in a feedback loop in the time that I'm with the patient is not that far away. And that's the real promise and power of this technology. And I also remember a time in my, I've led large analytic teams of clinicians, data scientists, engineers, analysts, who all work together to create this same type of insight from data. And I remember a day when I would go to an analyst and I would say, hey, tell me all the patients you have with pre-gestational diabetes. And then they'd go back, they'd crunch the numbers for a week. They'd come back and I'd say, oh, now I'm really interested in those that are female and African-American and which zip codes they live in. Okay, go back 2 weeks later, they'd come back and give me that answer. And then I'd say, okay, now tell me of those females, how many of their children actually have diabetes as well in their lifetime? And guess what? We don't track that. We don't track those connections or that longitudinal data. Anybody that's in this audience that has tried to map mothers to babies and the longitudinal data to then report an outcome, you know how hard it is to do that. And I think what really excites me about the technology is exactly where Cheyenne is going, where like there are improvements to documentation that seem really boring and mundane and take a small thing out of the workflow for clinicians. But given the clinician burnout and the burden that we're facing today, and as a result of the pandemic and COVID-19, and the extra work that everybody's putting in to document things that we can pull out of, we have to make it easier. We have to make it relevant, and we have to make it trusted. And I think these are all, I've adopted technologies over the years. I even am old enough to have carried a beeper at one point and answered that beeper by phone. So in the time that I've moved from a beeper to being able to pick up a data insight from NLP generated clinical note insight, it's an amazing time to be in medicine, and I can't wait for the next 5 or 10 years to see what comes next.
I feel like I should snap like we're at a slam poetry event. That was fantastic.
I can get very excited too.
No, it's transferring to me. I'm getting excited. All right, let's switch to how do you all envision the future? And Inez, I think this one I'm aiming at you specifically again, so I want you to keep that going. How do you envision the future of user experience in healthcare applications, and what role can these technologies play in improving clinical decision making? I know we've already touched on it a bit, but just to like stay here for a moment. And I know that you mentioned virtual assistants could be beneficial. Is that a case we want to talk about?
Yeah, I've got a couple of use cases that I think are really practical, and I think this really came out of the future of healthcare with generative AI, my submission in the IMO brief, and where I see like tangibly in the next 12 months that I think we're really making strides in applying generative AI to really revolutionize the way we do healthcare is in 2 ways. The first is the visual health assistance. And I really have been following this a lot, and I think the personalized health information, the answer queries, everybody is not a stranger to being asked the same questions over and over and over again by multiple organizations in healthcare that should be talking to each other. And I think this way is the most practical way to automate the collection of information that's needed to then be able to use in a structured way that is interoperable. And so I think virtual health assistance in every practical sense is the most natural progression and application of generative AI, and one that will be trusted and one that can be relied on. I think it is very transparent. You state an answer, you check your answer. Easy to trust and then verify. And then I think the second one is, actually Cheyenne mentioned it earlier, I think there is so much clinical insights and information in the clinical evidence base and the peer-reviewed literature that never gets touched. I mean, I am barely able to keep up with my own peer-reviewed preventive medicine journal that comes on a monthly basis electronically, let alone everybody else's peer-reviewed journals in different specialties. And so I think generative models can really expedite the research by analyzing very quickly and very effectively the amounts of scientific literature and generate hypotheses that I don't even think we think of today or have the insight to generate ourselves. And I think this will really accelerate really the discovery of new treatments. And I think it'll just speed up what is already happening today in a way that actually brings the evidence base to patients in a much faster way.
Certainly. All right, we are at the last of our prepared questions. So for all the attendees, if you want to pop something into the Q&A, now's the time as we go into this last one. So for you all, how do you think generative AI might reshape healthcare in the next year or 5? And what transformative effects could this have for your role and or your organization? Amal, we're going to start with you.
I like to take a little bit of a reflective, maybe let's talk a little bit about my history. So I'm an informatician. I'm also a software developer too, and a clinician and a bunch of other hats. But in my career, I've developed a couple domain-specific languages. And if you're not familiar with domain-specific languages or DSLs, they're basically high-level ways to work with what technology you have behind the scenes. So this may be a proprietary schema, this may be a proprietary tech stack, but it is allowing a person to kind of like a high level. If you're not familiar with HL7, they're a huge standards organization, but they have their own DSL and CQL. So they're pervasively used. But what happens is over time is that the language of the medicine evolves, but nobody persists the DSL behind the scenes. And so the DSL kind of falls short. Where I look at generative AI, large language models, all of this is it kind of takes out that ambiguity or try to develop something novel and then literally leverage the insights or leverage the data directly. And it's really what Inez was talking about is the amount of time and effort it takes to kind of do some really easy high level analysis, which we perceive as clinicians as high level analysis. It takes an analyst weeks to just come up with a result.
Months.
And it's I've seen it. All three of us come from a domain which requires a lot of analysts, a lot of implementations, a lot of data scientists, and we've seen this happen over and over again. So where I see this type of technology is really in the data enablement to support many use cases. It's getting back onto my philosophical soapbox. It's a new way to really engage with data or engage with a certain context and literally stop trying to figure out how to force feed maybe the development of a DSL or even a novel UI. It really allows us to use our natural language to interact with it. And that's where I see this technology taking us is instead of having to sit there and come up with a brand new user interface or come up with a new way to define something, this allows us to use natural language to interact with something and really allow the user to express what they truly need. And that's where I see this taking us in healthcare. So you bring it back to the clinician, let them operate like clinicians, avoid the burnout, let them do every single activity to make sure that that patient is happy, engaged, and most importantly, compliant with the treatment paradigms. Make sure that they are, taking their medications. That's a hard thing to do with patients, but with this type of technology, we can start understanding their body language, maybe give us information back to tell us, hey, maybe you need to change your narrative just a little bit to make sure that this patient gets engaged. And so it allows us to be very native with our language and operate as seamlessly while everything else behind the scene is being done for us. So I'll get off my soapbox. I'll pause there.
We brought you here for your soapbox, so I appreciate it. Xiaoyan, can we go to you next?
Thank you. Yes, totally. First, it's so lovely. I share the excitement and as an MO you have here. Let me tell you, as an NLP scientist, for the past year, every day I spend 2 hours at least reading all the literature, scientific discoveries, and NLP work, all the progress in the scientific NLP large language domain. So it's never in my career. I've been in this career for almost 20 years like this. Because as I said earlier, every day there are new papers, new models, new applications built. It is an extremely exciting time being in the field of AI. So that is the excitement I really have in the past year. So in terms of the future, it's very hard to predict the future, honestly. So on my end, I think I can foresee that in the clinical care workflow domain, I think it's probably a little bit slower because, it is related to every day how we treat our patient. Every second, we want to make sure it has a proven, safe to be efficient and also secure. So I think that end, it's probably progress a little bit slower. However, I think on the analytics end of the clinical data, there was a lot of excitement could really happen there. As I touched earlier on how we really integrated all the data and the knowledge to really enhance insight generation. And as you also touch on those. So in my end, I really see, 3 things are important. One is really the data. The other is our current understanding, and then technology put all those things together and then generate insight. So I think all the data behind all the systems we collected is really will be the center of the excitement for the next couple of years. Thinking about now you have 800 million data collected, you can accumulate a lot of research evidence, insight to really understand a lot of diseases, how the genetic causes of this disease, how the SDOH or environmental factors affect those disease progress, how the symptom signs really triggers the screening of the disease, how the disease really progressed, and what really are the risk factors on those disease progression, and then for each treatment, how well they really performed. All those are now becoming available and can be analyzed to understand the whole patient journey and the disease burden of it. I think, on the healthcare end, so the excitement really coming from all those data with this technology. Now thinking about taking all those data and knowledge into the life science space, how that can really drive the new discovery and the new compound. In the past, let's say it started with 10,000 compounds at the, after 3 years, and then you find like 5 compounds maybe effective. Now with AI, you can really significantly shorten that time to effectively find 5 within a year. For example, I actually see research actually shows that already. So on the drug discovery end, that's what it is. And also the clinical trial now, which is the most costly and time-consuming step. How we use technology, really help designing and also find those patients who treating what patients at where. So all those information can be put together at one platform, analyzed. And at the end, it, shorten extremely on the drug approval process to FDA and then to the post-marketing surveillance. And so once the data get into the practice, then we follow those drug. Because of clinical trial only like 1 year, 2 years, a lot of long-term effects were not really seen. So post-marketing surveillance, we can really do a lot of research using the data to analyze adverse events possibly appeared after 5 years maybe, or some of those other situations. There are a lot of excitement in the life science also. Overall, I think, what we as an NLP scientist really want to see how we can make AI responsible, trustable, and also realistically deployed in the real world setting. So that's what I see in the next year or 5 years. I can pause here.
Thank you, Xiaoyan.
I love it.
Inez, take it away. I know that's a perfect transition for you.
I know. I love this conversation, and this is probably the most fun I've had in opportunity like this in a long time, because we get to actually pontificate, right? And think about how this could be really useful to everyone. But I'm going to end with like grounding us maybe in like what, and if I were part of the audience, I would maybe want to hear like, what is the no regrets work that I could be spending my time doing in using this that is going to contribute to the future that we describe, and also probably make it even better, because we will have learned in the process what it's all about, and what to look out for, and how to participate even in it. I think to myself, like, if where we can head, and if you were to spend your time applying generative AI to create, just like Cheyenne and Amal said, a clean, comprehensive, trusted data set where you can apply unlimited querying so that you can, really analyze vast amounts of different types of data, EMR, claims, supplemental, self-reported, financial, banking, consumer data all together, where you can really generate the insights in a comprehensive way and make it very personalized to the patient in its output for an improved health outcome. That is no regrets work. It really is. And that's on the data improvement side, because generative AI sits on top of the data that it is. So if you don't have good data in, you're not going to get a good inside out. And I think a lot of the NLP work that's going on really helps to build and achieve that, right? And then I think on, the clinical side, for anybody who has a passion and an interest in being a part of this, spend your time identifying the very practical use cases where AI could enhance or improve or generate a better or faster response to or output of. I had the pleasure of writing a population health analytics textbook with a co-author of mine, Dr. Martha Sylvia, where 2/3 of that textbook is dedicated to creating, normalizing structured data. And I'd like to see in my 5 years, I'd like to see, well, first of all, I'd like to see a second version of that textbook for personal reasons. But I'd like to see in that second version, I'd like to see that go down to, hey, just use the technology that already exists, buy the technology that makes sense for you and your organization, and then dedicate the entirety of the rest of the textbook to developing the use cases that drive impact and that really matter in direct patient care, direct patient impact, and improving the health of the population. So I'll leave it at that. And I've had so much fun. Thank you.
We are so pleased that you could be on this panel. I'm a little jealous, and I'm like, I wish I could just keep this group together for all future panels because you've all played so well off of each other. We've now come to the end of prepped questions. We have a couple in the Q&A that we'll hit on. So Kathy Hertgen writes IT reports for an academic medical center and has done so in healthcare for 15 years. They are asking, what is your fear that AI will not satisfy accuracy related if used exclusively by providers? AI currently makes mistakes on general population, use on ChatGPT. Does it worry you all regarding adoption in healthcare? And they see research as the first application.
There's a couple of approaches. Yes, large language models pervasively have some issues. We know this. They are biased, they're hallucinated, they're trained on a snapshot of time, but there's also ways to augment, to provide them a rich set of what you need to from your domain to augment the results back. And so you'll hear technologies like RAG approaches, which is retrieval augmented generation approaches. And then additionally, there's other ways too. It's like, I think in November, OpenAI released the assistant function approaches too, where you can really pivot and provide additional data to augment the results back. So there's ways to eliminate that type of hallucination and bias. There's also ways to put guardrails too on the LLM itself. And literally it's called guardrails. And so guardrails, fine tuning, using augmented sources really can help out to solidify the use case. But it's what we were saying, us three in the middle of this webinar, is it takes a lot of experimentation. And I wish folks joined the call before, because we were joking about the generalities of LLMs and generative AI and how we kind of curtail it to a specific use case. And so, yes, we understand there is limitations to it, but there's ways to go and leverage other technologies to augment those limitations and overstep them. So, yep.
Yeah, I think I'll jump in to say that I think clinicians are especially trained and perfectly suited to play a role in understanding and calling out the ethical considerations around the application, and even the responsible development and deployment of these models. I think clinicians are trained to be skeptical and trained to be able to ask the right questions of what are the inputs? How did it calculate it? What is it telling me? Should I pay attention? Should I not pay attention? How relevant is it to the patient population that I would apply it to? And what is the action that I would take that would make me do something different as a result of knowing this information? And I think clinicians are very trained to do just that, to do that differential diagnosis and get down to one committed diagnosis. And I think they could do the same here.
I can take a little bit from the NLP and AI information retrieval point of view. So number one, I know AI hallucination it seems such a big word for anybody who cares about the accuracy of the problem. Hallucination makes it sound like it's just getting so wild, which is true and not true. Which is true because, early days, GPT does hallucinate and generate those false results. But on the other hand, it's true, meaning, any kind of information extract task, there's, those standard metrics we measure the performance called the recall procedure and F1 measures. So they are just part of those false positive. It's just like that. It's nothing new. We just use it in different terms to make it scary. So that's one thing. On the other way is, you know, good standard part of it. Because thinking about, we've been joking in the past 20 years, if you have a room of physicians asking the same clinical question, everybody give you different answers. It's very hard to agree upon things in medicine because of the complexity of the problem. So thinking about, you know, even you have a group of experts, you still very hard to reach agreements. And so the system, I think I wouldn't say it's fine to have it. We keep improvement, as Amo just mentioned. There are, you know, methods, RAG, and fine tuning, all those fine methodologies we as NLP scientists have been performing, but we keep performing, make it better and better. But at the end, nothing is perfect, especially in the field of medicine.
Thank you all. I do want to let you know that somebody that's attending has gotten goosebumps from what you have said. So we have generated excitement, and that makes me excited again. One question is, no one has mentioned bias on generative AI inputs and the effects on outputs. Can you all speak to that a little bit?
Yeah, I'll speak to that because I spend a lot of, that's where I spend most of my time, is identifying where we can make improvements, how we can make improvements, and how we can actually apply some of this to advance health equity. And, you know, a model is any model, any algorithm. It's not specific to generative AI. This is anybody who's developing a query out there in the world and applying it to a data set has the potential to create a biased output. And I think this is where we still need to work as teams. We still need to have a variety of different inputs, a diversity of thought when looking at the outputs of some of these models, so that there is not only representation, but somebody who's going to see if they see themselves in it and will ask the tough questions of it, whatever that output is, to ensure that we are thinking about it in all aspects and becoming responsible users of it. And I think the most important thing is to include the folks that you're going to use it on, right? Or use it with. Include the clinicians that will be making decisions off of it to give feedback. Include the patients that it would impact to provide feedback, and make sure it's of diverse and collaborative means in teams, so that you're constantly thinking about all of the different ways. And don't be afraid to beat it up. I mean, it's that skeptical optimism. Like, you can go into it and say, I want it to work, but then have an entire session that's dedicated to picking out everything that's wrong with it. And not to make it go away, but rather to make it better. And I think if we take that approach with anything that we do, regardless of whether it's new technology or existing workflows and processes, we'll make a better outcome, for sure.
I can add from NLP Sense point of view on that, on the technology itself. So actually in the community, we have a lot of discussion on limitations of technology itself. So the bias and also the transparency of the data, because actually OpenAI, for example, has never disclosed what kind of training data they use to train the model. In my perspective, I don't really trust always on something I don't know what it's trained from, because automatically it inherits those biases. I'm not really aware. It really made me think, how should I really use the model generated from the trained the data unknown, and then use it for other use cases. So those kind of bias has been widely discussed in the community. Also, security is another thing. If you notice, there was a Twitter group talking about security. If you keep pumping, you actually be able to get some of the HIPAA data out, some of those, you know, there's those issues there we are aware of, and also the community have a lot of methodologies now generating to make it better.
Thank you all. All right, we're at our last question from the Q&A portion. For each of the panelists, if you have one success story that you like that for the use of AI in clinical medicine, what would that be?
I can start because we recently, last November, we published a paper called Auto Criteria using large language models published in JAMA. It's actually have a lot of impact. New York actually came to interview me for that paper. What we did is using large language model processing the text of inclusion, exclusion, eligibility criteria, make it computable and link to the real world data. Then it can talk from the criteria protocol to the patients themselves. So, those kind of things I like to share with the community. And then, feel free to read the paper and let me know if any questions related to it.
Awesome. One of my favorite things when I first met Xiaoyan, she said that she has a Teams chat that's science fun for everyone, and she sends new papers every other day, and I love that spirit. So I think we'll close out here. I hope everybody is as optimistic as this group is. I think do what Ines says and keep scrutinizing things, want it to work, and just keep up with these smart people, and I think you'll be in great shape. This webinar will be available after the recording, and thank everybody for attending. Bye. I don't remember how to end this.